Well, thank you very much for coming to Healthwatch USA's webinar. I'm Dr. Kevin Kavanagh, Board Chairman of Healthwatch USA, and I'd like to welcome you to our 2025 webinar, Combating Infectious Disease Challenges, Have We Gone 20 Steps Forward or Backwards? We chose 20 steps because today is the 20th anniversary of Healthwatch USA. Unfortunately, things do not look better, both for the healthcare delivery system in the United States and for public health in general. Misinformation permeates the internet, and this month the CDC was physically attacked with almost 200 high-velocity bullets hitting the building, along with the killing of a police officer. And just this week, a Washington Post headline read, "White House fires CDC director who says RFK Jr. is weaponizing public health." In the previous months, the CDC has not only endured an armed attack, but the CDC has also had mass layoffs, along with the replacement of the ACIP or Vaccine Committee members with members who many believe are anti-vaxxers, and the resignation of the co-lead of the coronavirus working group, and the resignation of Fiona Havers, who oversaw the CDC's respiratory virus data, also took place. In addition, there were orders to promote vitamin A as a measles treatment, along with restricting the COVID-19 boosters availability, which would expose our general population to increased risks of long COVID. This week, we had 4 additional top CDC officials resign. Deborah Howry, the CDC's Deputy Director; Daniel Jernigan, head of the CDC's National Center for Emerging and Zoonotic Infectious Disease; Jennifer Layden, Director of the Office of Public Health Data, Surveillance and Technology; and Dimitri Daskalakis, head of the CDC's National Center for Immunization and Respiratory Diseases, and he also wrote a scathing resignation letter. In face of the loss of federal infrastructure and support, local and state public health efforts have become even more crucial. In support of public health, this webinar will address a number of topics and strategies, which include the importance of vaccinations, worker safety, elimination strategies, and the impact of bird flu on humans and our food supply. We will also talk about good viruses or phages, and how they can be used to treat antibiotic-resistant bacteria. Finally, and most importantly, we will be discussing the importance of misinformation and disinformation on implementing public health strategies. Before we start this program, I would like to briefly touch on the strategy of masking and the difficulties faced with its implementation. Or similar barriers found with face mask adoption can also be found with other public health strategies. Dr. Vinny Prasad, the current FDA Director of the Center for Biologics Evaluation and Research, has made 2 important observations regarding the strategy of masking. First, poor compliance can thwart bioplausibility, and prolonged exposure time can thwart a marginal change in particle exposure. Thus, if you do not wear a mask correctly, it will not provide protection, and dosage is important. When we talk about the importance of dosage, we need to realize that a virus does not have eyes or the ability to move. Its encounter with the cell and the cell receptor is entirely random. Similar to a battlefield where a single blind gunman tries to hit a target, it's unlikely to happen. But with 1 million blind gunmen, one may hit its mark. So dosage is important. Jha et al. Demonstrated the importance of dosage. These researchers compared short airline flights without masking to medium and long airline flights without masking and observed a 4.66 to 25.93-fold increase in transmission, respectively. However, no transmission was observed with long airline flights with enforced universal masking. A 1-hour increase in flight duration was associated with a 1.53-fold increase in the rate of transmission, or in the incident rate ratio of cases. The researchers recommended that masking should be considered for long airline flights. The dosage effect is illustrated in this table by the Colton and Rockefeller Foundations. This table estimates the exposure time for one to become infected by a respiratory pathogen. If someone in a room is infected and no one is wearing a mask, it will take approximately 15 minutes for transmission to occur. Now, in that same room, if everybody's wearing a cloth mask, it will take 26 minutes for transmission. Surgical mask, an hour. Non-fitted N95 mask, 6.25 hours. And a fitted N95 mask, 25 hours. But in a medical setting, it's very easy to have 25 hours of exposure during a 1-week period of time. Thus, you need to do more. A layered approach is necessary. Now, when we say a layered approach, we mean doing more than one thing at the same time. And that's scoffed at by some. They want a simple, single-step solution. But everything in medicine, from the treatment of complex cancers to that of a simple cold, is a layered approach. My mother, when I had a cold, would recommend keep warm, rest, vitamin C, chicken noodle soup. That's a layered approach. So everything in medicine is a layered approach. That's the rule. It's not the exception. A major review by Thomas Jefferson et al. Failed to show a beneficial effect of masking. This review was published in the Cochrane Database Library. The review has received widespread attention, and I feel its findings have received too much weight in medical decision-making. A major caveat published in the review is as follows. Relatively low numbers of people follow guidance about wearing masks, which may have affected the results of the studies. And that's an important caveat. In addition, the design of some studies have come into question. For example, one highly quoted article by Loeb et al. In 2009 stated, use of such a surgical mask was required by the Ministry of Health and Long-Term Care when providing care to or within 1 meter of a patient. Well, in my opinion, the design of this study was not optimal to prevent spread of pathogens through the air. 1 meter may work for large droplets, but not for airborne pathogens. So for me, it's no surprise that the intervention arm of the study did not demonstrate effectiveness in preventing transmission. Now, 2 major reviews did find masks reduce transmission. The first was by Boulos et al. That analyzed 75 studies, including 4 randomized controlled trials, and concluded, despite the risk of bias, that wearing masks, wearing high-quality masks, N95 respirators, and mask mandates generally reduced SARS-CoV-2 transmission. In another review by Green-Halja et al., reviewed over 100 published reviews and studies and concluded that, first, there's strong evidence for airborne transmission of SARS-CoV-2. Second, that masks, if worn correctly and consistently, are effective in reducing transmission and show a dose-response effect. Third, respirators, such as N95 masks, are significantly more effective than medical or cloth masks. And fourth, mask mandates overall are effective in reducing community transmission of respiratory pathogens. The statement, we need more high-quality trials, is true, but you need to realize, to be high quality, a randomized controlled trial must be double-blinded or significant biases can occur. And how can one construct a double-blinded trial for masking? The subjects are going to know whether or not they're wearing a mask. And if someone knows they're wearing a mask, they may undertake more risky behavior. They may be more willing to see COVID-19 patients and to stay with those patients longer, thus increasing their exposure dosage over the control group. And with public health trials, randomized controlled trials often cannot be ethically performed. Take, for example, the effectiveness of parachutes, which was the subject of the famous BMJ article written by Smith and Pell regarding ethical implications of randomized controlled trials. I mean, after all, who would want to be in a control group of a parachute study? But there is still certainly a demand for randomized controlled trials. Vinny Prasad has written, you can't have a double standard for evidence. Masks and ivermectin both have no evidence to justify them, and both, quotation marks, don't work. Until that evidence is marshaled, you can't say that ivermectin doesn't work, but masks might. Well, I feel this is comparing apples and oranges. And the analogy compares the evaluation of public health strategy to that of a drug trial. Drug trials oftentimes require as little as 5 to 10 minutes per day of compliance, such as taking ivermectin. Clinical health trials often involve health strategies that sometimes require 8 hours a day, 5 days a week compliance. This is entirely different. Drug trials can be easily double-blinded, but this is next to impossible with public health strategy trials, such as those involving masking. And as I've discussed, biases are frequently present and often permeate non-blinded public health trials. So I'd like to discuss a few studies which have shown masking to be effective. The first was a large community randomized controlled trial performed in Bangladesh by the Innovations for Poverty Action, along with Yale and Stanford universities. They evaluated 340,000 adults. This trial is designed to determine not the effectiveness of masking, but the effectiveness of surgical and cloth mask distribution, along with education. Thus, both arms of the trial were masked, which should have blunted the results. Overall, there was a 29 percentage point difference in masking between the two arms of the trial. Surgical masks resulted in an 11% reduction in symptomatic SARS-CoV-2 seroprevalence. So one could argue that if the two arms had either 0% or 100% masking, the effectiveness observed would be as high as 38%, and this was with surgical masks. If N95 masks were used, one would expect this effect to be even more significant. Shown in this slide are 4 articles regarding the beneficial effects of students wearing masks while at school. The last study by Calgar et al. Was published in the New England Journal of Medicine and found, and I quote, the lifting of masking requirements was associated with an additional 44.9 COVID-19 cases per 1,000 students and staff during the 15 weeks after the statewide masking policy was rescinded, end quote. Now, it needs to be remembered that in community settings and schools, the exposure to SARS-CoV-2 would be expected to be lower than that which a hospital worker is exposed to. Regarding ivermectin, there have been at least 3 well-designed, double-blind, randomized controlled trials which failed to demonstrate a beneficial effect of using ivermectin to treat COVID-19. These findings, along with those in other trials, make ivermectin, in my opinion, an unsuitable candidate for the treatment of COVID-19. And in my opinion, research dollars would be best spent elsewhere. So some concluding observations. In clinical trials in healthcare settings, compliance is often suboptimal, and masks are sometimes used as a sole strategy. Maybe the reason why many of the trials in healthcare have not shown a beneficial effect of masking is because viral dosage and exposure time are too high or too long, which can lead to an infection with even one lapse in protocol. Thus, using a surgical or even a respirator as the main strategy in healthcare setting may not be adequate. Other strategies to lower viral dosage, such as clean air and increased ventilation, need to be incorporated into the facility. However, during a pandemic, advising the public to wear an N95 mask for short exposures, such as going into a restaurant to pick up a takeout order, is a sound strategy. Now I have to do some housekeeping. Now, all speakers have declared conflicts of interest that may affect their presentation. All speakers have either no relevant financial relationships, which would affect course content, or that financial relationship has been mitigated. Now, credits obtained through Southern Kentucky AHEC include Category 1 AMA credits, or physician nurse practitioner credits, social work, physical therapy, occupational therapy, respiratory, community health worker, EMS, and Kentucky nursing credits. You must also complete an evaluation form at the end of the course. Partial credit can be awarded for these credits, but only commensurate with the amount of time that you attend the webinar. So if you attend 2 hours of the webinar, you can only declare 2 hours credit. It should be noted that Southern Kentucky AHEC's website and their form doesn't reliably work with Internet Explorer or Edge. A disclaimer, all information presented at this conference is the express opinion of the presenters and moderators and or participants, and not necessarily that of Healthwatch USA or its partnering organizations. Nothing in the presentation should be construed as medical advice. One should always consult your healthcare provider before making treatment or healthcare decisions. Now, before we start the webinar, I'd like to thank our strategic partners who, without their help, this webinar would not be possible. These include the Massachusetts Nurse Association, Southern Kentucky AHEC, and the Connecticut Nurses Association. Shown in this slide is the webinar's agenda. You can download this agenda from healthconference.org. So go to https:// healthconference.org to download the agenda and also the speaker's slides. Now, at this time, I would like to introduce Dr. Simonotti. She will be our moderator for the afternoon session. Dr. Simonotti is a nurse researcher and associate professor at Emory University. She has sat on the advisory and grant approval committees for AHRQ and VHA. She has published groundbreaking research regarding the importance of nurse staffing and patient safety. Dr. Simonotti, the floor is yours.